Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you for joining us today and our friends at Generations Family Health Center for hosting today's session, Hypertension Update 2024. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consulting. In addition, he's been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, you may begin.
Thank you very much, and good morning, everybody. It's nice to be here and nice to be with you. Today we'll talk about hypertension and some of the newer aspects of this problem and how to deal with them. I have no disclosures, nor do any of the other people that are involved in the production of this CME session. And the MAVEN Project designates this for 1 hour of Category 1 CME credit. But we're not going to start with today. We're going to start with what I might refer to as the olden times. Franklin Delano Roosevelt, President of the United States, famously had hypertension, and he had considerable hypertension. If you look at the data, in those days there was no real treatment, and it wasn't considered to be as much of a problem as we now realize that it is. So, for example, he was first noted to have hypertension when he was 55. By 59, his systolic pressure was 188 over 105 at the time of Pearl Harbor. 2 years later, he had uncontrolled blood pressures with BP of 210 to 260 over 112 to 150, something that's really unimaginable here. And went through or famously the Tehran and the Cairo conferences. And a year later, in 1944, his blood pressure was noted to be 240 to 260. He was noted to have congestive heart failure, and descriptions of him at that time show that at the time of the Yalta conference, he was in congestive heart failure. Nevertheless, he managed to meet with Lucy Rutherford as a side effect, as a side comment, if you will. And then on April 13th, 1945, he died suddenly of a cerebral hemorrhage, which the doctors at the time thought were unprecedented and, quote, came out of a clear sky. No indication of imminent danger, they said. Well, times have changed, haven't they? The learning objectives of this talk are to help you use proper technique when measuring blood pressure, to be aware of and seek blood pressure goals, to implement a strategy for initial and subsequent both non-pharmacologic and pharmacologic management, and to recognize when to look for secondary drivers and causes of hypertension. Hypertension is indeed a pervasive problem. The most recent statistics published by the American Heart Association are that 122 million people in the United States have blood pressures that are over 130 over 80, which is almost half of the adults. 3 out of 4 people have uncontrolled hypertension. There have been 124,500 deaths in the United States in 2021, with hypertension as the primary cause, and the cost is considerable. Hypertension increases as we age. This is the most recent data showing that over the age of 65, 70 to 75% of people have hypertension. And over the age of 75, 80% of people have hypertension. So it's really considerable. Blood pressure is now known to have consequences. People, the diagnostic codes are I-10 and I-11.9. I-10 is, quote, benign or hypertension. There is no such thing as benign hypertension. If you have hypertension long enough, you're going to suffer the consequences. This is old data published over 20 years ago, a meta-analysis of 61 studies of over 1 million adults looking at ischemic heart disease mortality. And as you see, there are a series of curves. This is, I think, this is systolic pressure. This is diastolic pressure. We'll just look at the systolic pressure for the moment. And you see there's a series of curves depending on age. So as you age, risk goes up. And as your blood pressure goes up, risk goes up. And as a matter of fact, the risk of cardiovascular death doubles for every 20 over 10 millimeters of mercury increase in blood pressure over 115 over 75. That low. There's association between blood pressure and other cardiovascular risks, not only cardiovascular mortality, but stroke, as you go from normal to elevated to hypertension, coronary artery disease, and myocardial infarction. I'm going to show you two trials here. This one, the SPRINT trial, really was a game changer. It was a landmark study that directly impacted the most recent blood pressure guidelines. The SPRINT trial was a randomized controlled trial separating the patients into two different groups. Standard treatment with a goal systolic pressure of under 140, and an intensive treatment group with a goal blood pressure of under 120. About 4,600 plus people in each group, 35% females, 28% of them were over the age of 75, and 30% African Americans. The primary outcome was a composite of MI, acute coronary syndrome, stroke, heart failure, or death from cardiovascular disease. Notably, they excluded diabetics because diabetics had been in a previous study. Here are the results. And you can see in the SPRINT trial as a whole, there was a 25% reduction in the hazard ratio, both in the primary outcome and in all-cause mortality. All-cause mortality was reduced. Even over the, I shouldn't say even over the age of 75, I should say over the age of 75, the results were even more impressive, with a 34% reduction. There were adverse events in the older age group. The most important ones were hypotension and injurious falls. But neither of those were enough to overcome the benefits of lowering blood pressure. This is a more recent trial that reinforces the data in the SPRINT trial. This is a trial recently published in the New England Journal called the STEP trial. It took place in China. 8,500 people between the ages of 60 to 80. And again, what was noted is the intensively treated group fared better than the standard treatment group with a 26% relative risk reduction. Now, there are three questions to ask your patients when you're, before you measure their blood pressure, not during, incidentally. Before. Were you rushing to get here or physically active right before this appointment? Have you been taking your medicine? Have you just had a cigarette? What's your diet and physical activity regimen like? And so now we'll look at measuring blood pressure. And of course, my question is, what's wrong with this picture? Put your answers in the chat. Legs are crossed. Okay. Any other? Feet off the ground. Yeah. Drinking caffeine. Arm is down, legs not on floor, coffee. Yeah. Any other? Talking. The patient cuff is too small. Well, in addition to that, well, I'll tell you in just a second. This, of course, is the right way to do it. Patient should empty his bladder, his or her bladder. Should be sitting in a chair, back supported. Knees, legs not crossed, feet on the ground. The cuff should be on proper size and on bare arm, not over clothing. No talking during. And probably after a few minutes of rest, to have the patient sit for a few minutes before you take their blood pressure. I'll tell you a story about a woman that I am very close to, who went to see the doctor before we took a trip to Ecuador to see her children, to visit with her children who were there, and she went to see a new doctor who happened to be from Ecuador. And when she told him that, while he was taking her blood pressure, he told her about how dangerous Ecuador was and how when he went home, he carried a gun and had protection, had protection. Well, this is while taking blood pressure, not that belongs on this side of the slide. So here are the guideline classifications. Okay, the previous guideline was JNC 7 in 2003. So it wasn't really updated from 2003 to 2017. Normal blood pressure has always been 120 over 80. And JNC 7 from 120 to 140 was considered to be pre-hypertension, and hypertension was considered to be over 140. In the newer guidelines, 120 to 130 is considered elevated blood pressure, and stage 1 hypertension begins at 130 over 80. That is, the definition of high blood pressure is a blood pressure of greater than 130 over 80. Now, if we look at some of the factors that go into blood pressure, one of them is salt intake, okay? The standard US mean sodium intake is somewhere between 2,300 and 4,700 milligrams of sodium per day, and high dietary sodium intake raises blood pressure. Limiting salt intake lowers blood pressure and reduces intracellular volume. Whether you're African American or non-African American, the results are better for blood pressure, then for pre-hypertension, both systolic and diastolic. So the next, we have a series of questions. Which has more sodium? One Hebrew National beef Frankfurter or 11.5 ounces of V8 juice? What's your answers in the chat? Okay. We have V8, V8, and both. Okay, and the answer is the V8 juice. This particular Frankfurter has 480 milligrams of sodium. Some Frankfurters have as much as 900 milligrams of sodium. The vegetable juice has 900 milligrams of sodium. Which has more sodium? One Panera Bread Southwest Caesar sandwich salad with chicken, or a slice of Domino's pizza, pepperoni pizza? We have one vote for the pizza. Another vote for the pizza. A third vote for the pizza. And the answer is the Southwest Caesar salad, which has, now the pizza has 830 milligrams of sodium, so it has considerable amounts of sodium. The salad has more, over a gram. Which has more sodium? One Chipotle burrito with rice, beans, etc., or one Olive Garden chicken marsala fettuccine entree? I have one vote for Olive Garden. Two votes for Olive Garden. Oh, three votes for Olive Garden. Okay, and the answer is the burrito. All right, now the pasta has 2.5 grams of sodium. This is more than, way more than what your daily intake of sodium ought to be. But the burrito has more. And this is the American Heart Association's Salty Six: bread and rolls, pizza, sandwiches, cold cuts and cured meats, soup, especially canned soups are a killer. Burritos and tacos. And if you consider buying food at the grocery store, 4% of your intake of sodium is found naturally in food, while 68% of it comes in processed foods from the grocery store. 15% is found in restaurant meals. So that's part of the strategy for sodium reduction. At home, avoid processed foods when possible. Read food labels. Buy low sodium versions of foods. Stick to fresh foods. Cook without salt. Try fresh turkey, chicken, and lean beef instead of cured and smoked beef, smoked foods like bacon, sausage, and lunch meats. Okay, and try to eat out at restaurants less often. And when you do, ask for low sodium dishes. Most restaurants are cognizant of what they call food allergies, so don't hesitate to ask. Encourage your patients to ask for low salt dishes, or have the chefs not put on extra salt. Okay, turning to aldosterone, Aldosterone has considerable effects in the production of hypertension. Aldosterone leads to sodium retention and volume expansion, in addition to the upregulation of angiotensin II receptors and a potentiation of the pressor response to angiotensin II. So here's, all leading to extracellular fluid volume expansion and hypertension. A clue is hypokalemia, either a low normal or a low potassium, despite a potassium-sparing agent or potassium supplements. This is just to point out that hypertension, when it occurs in children, leads to major adverse cardiac events in adults. Okay, so here were 25,000 children with hypertension compared with matched controls, with large number of matched controlled, a mean age of 11. And you can see that the number of major adverse events is considerable, even at young ages. So you're talking about over a double hazard ratio before the age of 40. So treated early. Now, there are some early markers of hypertensive cardiovascular disease, or what's called end organ damage. But early markers of hypertensive cardiovascular disease, blood pressure, an exaggerated blood pressure response to exercise on a stress test. So on a stress test, if women achieve a blood pressure of over 190, men over 210, that's a hypertensive response, even though the blood pressure may be normal at rest. And then there's the loss of the nocturnal dip. So if you look over here on the left, this shows the circadian variation of hemodynamics and catecholamines during the day. The blood pressure and catecholamines are elevated or are raised, and at night they fall, with being at lowest, at something like 4 in the morning. Okay, and there are what are called dippers and non-dippers. So this would be a dipper, showing the fall from 4 to 6 in the morning, and this would be a non-dipper, where the blood pressure never falls at night. This would be particularly true in a patient with obstructive sleep apnea, right? Because they never really get deep sleep, and this has been shown to be associated with increased increased major cardiac events or worse outcomes. So there are other early markers of hypertensive heart disease. Left ventricular hypertrophy, either on an ECG or on an echo, diastolic dysfunction, and coronary artery calcium. Coronary artery calcium, as you all know, is a sign of atherosclerotic coronary artery disease. The only way you can get calcium in your coronary arteries is if you have ASCVD. Vascular marker would be increased carotid INT. Renal marker might be microalbumin or reduced kidney function and changes in the retinal arteries. Okay. Now, turning to treatment, there are a number of non-pharmacologic interventions which are advocated and useful for both the prevention and the treatment of hypertension, including weight loss, For every kilogram of weight loss, there's a millimeter of blood pressure reduction. The DASH dietary pattern, which is a diet rich in fruits, veggies, and low fat. Sodium restriction. The optimal goal is 1,500 milligrams a day, but under 2,000 would do for starters. Increase in dietary potassium, an increase in physical activity. So exercise helps hypertension. Moderation of alcohol consumption. If you ingest more than three or more really drinks per day, it's much harder to control blood pressure. And the use of CPAP for obstructive sleep apnea, if you use it more than 4 hours a night, has been shown to reduce overall blood pressure and especially nocturnal blood pressure. These are just two studies dealing with weight loss. This is the result of bariatric surgery in a 5-year follow-up with a weight loss of 55 pounds. At the end of the 5 years, 47% of the patients were no longer needed medicine versus 2.4% treated whose obesity was treated with medical therapy. This is one of the new GLP-1 agonists, tirzepatide. In the 36-week follow-up, blood pressures fell. So here are the 2018 physical activity guidelines, right? Move more and sit less. Emphasize to your patients that any amount of physical activity has health benefits. Everything counts. The goal is 150 minutes a week of moderate physical activity. That is a half an hour, 5 days a week. Physical activity has really important. Physical activity is actually better than a drug because it helps prevent 8 types of cancer. It reduces the risk of dementia. It reduces all-cause mortality, heart disease, stroke, high blood pressure, type 2 diabetes, and depression. That it improves bone health, physical function, and quality of life. And for older adults, physical activity also lowers the risk of falls and injuries from falls. It doesn't matter what kind of exercise training you engage in, aerobic, resistance, combined. In my opinion, a combined program is the best program. And this is the exercise prescription. When in the days when we were writing prescriptions on prescription pads, which is not too long ago, I would actually write this out on a prescription and hand it to the patient, right? So the frequency should be 3 times a week, but more is better. The intensity should be, moderately hard or brisk but comfortable walking, for example. More vigorous exercise is probably better. Walking has the equivalent benefit to running, just takes longer. If you're following target heart rates, somewhere between 65 and 80% of the maximum predicted heart rate. The duration should be somewhere between 30 and 45 minutes. And don't forget a warm-up and a cool-down session. Turning to drug therapy, these are the treatment thresholds for adults with high blood pressure. If your 10-year risk is less than 10%, then and you have blood pressures under 130/80, greater than 120, but less than 130, then lifestyle measures are indicated. If you have stage 1 hypertension, intensify lifestyle modification and start medication when the blood pressure hits 140/90. That's with a low risk patient. With a higher risk patient, a patient with diabetes, a patient with chronic kidney disease, the recommendation for blood pressures under 130 is the same, but start medication when the blood pressure is over 130. There's a new calculator for risk called the PREVENT calculator, put out recently by the Heart Association, which is going to identify people at lower risk. So according to that, more people will be in this group than in this group. And some people that previously were thought to need pharmacotherapy at very low stages may not. Some of the major findings on hypertension since the guidelines are listed here. Out of office, blood pressure readings are recommended. It's the most practical method to document blood pressure for medication titration. Screen patients with difficult to control or resistant hypertension screen them for primary aldosteronism. I talked about young adults, so don't delay treatment. Lifestyle modification, in addition to preventing and treating blood pressure, also improves the effectiveness of pharmacologic therapy. Intensive blood pressure control is not associated with increased hospitalization and does not increase the risk of orthostatic hypotension. And asymptomatic orthostatic hypertension in hypertensive adults is not associated with higher rates of cardiovascular disease, syncope, falls, or acute renal failure, and is not a reason to withdraw treatment. It may be a reason to reduce treatment, but not to withdraw it. For older adults, intensive blood pressure lowering may, or at least partially, arrest cognitive decline, and lowering blood pressure over the years, not only in older adults, has also been shown to reduce the risk of new onset diabetes. Multi-level, multi-component implementation strategies are emphasized, and I'll talk about that again later on. So, what about the choice of drug therapy? The major determinant of cardiac risk reduction, or cardiovascular risk reduction, is the amount of blood pressure reduction and the achieved blood pressure, not the choice of drug, with a couple of exceptions. One exception is that in the ACCOMPLISH trial, an ACE inhibitor, nifedipine, amlodipine, an ACE inhibitor and amlodipine combination were better than an ACE inhibitor diuretic combination. And then there are patients who have comorbidities who may have non-blood pressure indications for medication, like heart failure, diabetes, AFib, or heart failure with preserved ejection fraction. Each class of antihypertensive agent will lead to a good response in somewhere in the range of 30 to 50% of patients, but there's a lot of variability, and if you give another drug instead, the results will be in the same ballpark. This just shows that over the many years back when the ALLHAT trial was started, we're talking about the 1990s. Comparing chlorthalidone, lisinopril, and amlodipine. The drug companies who manufactured those drugs were all competing to show that their blood pressure medicine was better than everybody else's. Well, that doesn't turn out to be the case. Here's a 23-year follow-up, and the curves are exactly the same. So the approach to antihypertensive drug treatment is that If there is not significant proteinuria, then initiate either an ACE inhibitor or an ACE inhibitor or an ARB. Those are considered to be roughly equivalent. With or without a dihydropyridine calcium channel blocker. If there is significant proteinuria, start with an ACE inhibitor. If there's not, start with any of the drugs, and then if the blood pressure remains uncontrolled, add another drug and go from there. This just shows that both indapamide and chlorthalidone are better than hydrochlorothiazide in terms of blood pressure lowering. These are the recommendations from the American Diabetes Association. The diabetes care standards of care in diabetes. For blood pressures between 130 over 80 and 150 over 90, start one agent. Well, lifestyle management and all, but start one agent. If there's not albuminuria or coronary disease, it's your choice. If there is, start with an ACE or an ARB. If the blood pressure is greater than 150 over 90, start with two agents. My own preference over the years has not been to start with to give two agents at the same time, but rather one at a time in order to make sure that the side effects, I can identify the source of side effects if there are any. But once a short period of time has gone by, a month or two, and the patient's tolerating the medicines well, then you can, combine them. The treatment target basically is 130 over 80, according to the newest recommendations. If you don't, if treatment is tolerated and the target is achieved, continue therapy. If you're not meeting target, add an agent from a complementary drug class. If they're still not meeting the goals, use spironolactone and or refer to a hypertension specialist. Now, there are a number of secondary drivers of hypertension, including chronic kidney disease, medications, of which the NSAIDs are the worst, are the worst actors, because patients will often take them and not tell you. Now, if you take, if you fall and have a minor injury and take a couple of ibuprofens, that's not really going to raise your blood pressure. If you're taking ibuprofen every day, that's a different story. ADHD meds, other stimulants, sleep apnea is a driver of hypertension, and primary hyperaldosteronism. So look for it in severe or resistant hypertension, patients with hypokalemia, patients with obstructive sleep apnea, and patients who develop AFib who don't have any other cause for AFib. Now, what about resistant hypertension? The definition of resistant hypertension is an uncontrolled blood pressure despite 3 or more medicines. But before you make the diagnosis of resistant hypertension, exclude the following: secondary hypertension, pseudo-resistance, right? Apparent hypertension due to lack of medication adherence or poor blood pressure measurement technique. Do you have a patient with resistant hypertension, or do you have a resistant patient with hypertension? Masked hypertension is hypertension outside of the office, but normal blood pressure in the office. White coat hypertension is high blood pressure in the office, but not outside. And then the management approach is to, again, exclude other causes. Make sure your patient is following a low sodium diet. It says here 2,400 milligrams a day. I would say 2,000 milligrams a day at least. Maximize lifestyle interventions, including enough uninterrupted sleep, his dietary pattern, weight loss, and exercise, and then optimize the 3-drug regimen. If that doesn't do it, make sure your diuretic is chlorthalidone or indapamide instead of hydrochlorothiazide. If that doesn't do it, add spironolactone. If you're still dealing with hypertension, the next strategy is at that point add a beta blocker. So we're talking about a third line drug, but at this point, adding a beta blocker makes sense, and or hydralazine, or substituting minoxidil for the hydralazine. So here is another problem, or another hypertension problem. 53-year-old asymptomatic African-American man came from the Bahamas. He moved to Florida and was seen in one of the clinics there, one of the safety net clinics there, with hypertension and type 2 diabetes. In the Bahamas, he was treated with valsartan hydrochlorothiazide and nifedipine XL. But in the 2 months since he got to the United States, he hadn't taken his medicines at all. His A1C when he arrived was 10.2, which he self-treated with diet and weight loss. His blood pressure on exam was 226 over 135, but he was otherwise normal. So what would you do? Send him to the emergency room because he has a hypertensive emergency? Order an ECG and basic labs, order an echo looking for LVH, order a nuclear stress test, quote, take 2 Valium and call me in the morning. That's it. Take off on the old expression, take 2 aspirin and call me in the morning. Or restart his meds and follow up in 2 weeks. Put your answer in the chat. Takers, hey? You gonna send this guy to the emergency room? Oh, okay. Here we have a response. Restart at least 1 med. Okay. And short follow-up in the office. I think you're right. You're right. So this is not a hypertensive emergency. These are hypertensive emergencies. The definition of a hypertensive emergency is a blood pressure over 180 over 110, whoops, with 1 or more of the following: hypertensive encephalopathy, intracerebral hemorrhage, a stroke, an acute MI, heart failure, unstable angina, dissecting aneurysm, acute renal failure, or eclampsia. So he doesn't have any of those. And this used to be called a hypertensive urgency, but that's probably a misnomer. Probably ought to just call it uncontrolled blood pressure. Yes, I would, if this was the first time that I was seeing this fellow, I would be doing an EKG and basic labs. I would be ordering an echo looking for left ventricular hypertrophy. I would not be doing a stress test because he doesn't have any symptoms. And I would restart his meds as suggested, at least 1, but possibly both, and follow up a short follow-up, of something like 2 weeks. So my approach to blood pressure goals is don't let controversies about what the blood pressure goals are keep you from initiating treatment. Okay? Don't let the patient say, I've always had high blood pressure, and that's an excuse for not trying to lower it. I use a stepwise approach. Aim for a systolic pressure of 140. If you can do that without adverse side effects, aim for 130. Smaller doses of 2 drugs may be more effective than pushing 1 drug to its max. That's an important consideration. So when you've given 1 drug, add a second drug rather than pushing it all the way up. And don't let therapeutic inertia keep you from changing or up titrating medicines. There are studies that show from the VA, I believe, patients were coming to the clinic having blood pressures of 150 or higher, and doctor didn't do anything. Don't do that. Do something. Have the patient take his blood pressure and measure it again in 2 weeks. Have him take it at home if he's not already doing that. Come back, in a week or 2 for another blood pressure, raise the dose or add whatever it is that you're using, or use another, add another drug. The point is, do something. Okay, and adherence to treatment is really important. People think they're taking their medicine every day, or at least they'll tell you they're taking their medicine every day, and maybe they are, and maybe they're not. So educate and counsel patients using, what are called motivational interviewing techniques. Simplify medical regimens as much as you can. So using fixed dose combinations can help where possible. Encourage self-monitoring of home blood pressure. Use 90-day refills instead of 30-day refills. I take a number of medicines and I can't stand going to the pharmacy every month. So 90 days is much better. And you utilize all of the tools at your disposal. That is a multidisciplinary team-based approach to care, and use telehealth strategies. So if the patient is taking his blood pressure at home, he can call you in 2 weeks and give you the results. Right? Read the results over the telephone or on a video call, and you can make your adjustments without having the patient have to come to the clinic. So these are all important. Ways of trying to control blood pressure. The more contact you have with the patient, the better the blood pressure control will be. And when I say the more important, the more contact that's not necessarily only you. It could be you, a nurse, pharmacist, if you have one available, medical assistant, reporting the blood pressures as often as possible in order to achieve control. So I close with this statement from Roger Blumenthal at Johns Hopkins. 120 is the new 140. Lifestyle modifications. First, high risk, add medicines at 130 over 80. Low risk, add medicines at 140 over 90. That's sort of that's kind of the summary of the treatment right there. Right there. And of course, to prevent a heart attack, take 1 aspirin every day. Take it out for a run, then take it to the gym, then take it for a bike ride. Thank you very much, everybody. And I'll be glad to entertain questions.
All right, we do have someone's hand raised.
Okay.
Okay, Heidi, you can ask your question.
Hi, thanks. I wanted to ask if I recently was listening to an article on hypertension, and any thoughts on starting with ARBs over ACEs? The idea being that if you have angioedema for an ACE, then you're basically excluding both ACEs and ARBs in the future. Whereas if you start with an ARB, there's less of a chance of getting angioedema. So that was this cardiologist's preference, was to start with ARBs.
There is if there is a very small risk of angioedema with ACE inhibitors. There is not really cross reaction with the ARBs. They're different compounds. So if you had angioedema with an ACE, go with use an ARB. If when you read articles about these things, given that there are more side effects of ACEs than there are of ARBs, meaning cough, mostly meaning cough, and the very small risk of angioedema, you might want to start with an ARB. I do sometimes. I do use lisinopril. You can do either one. I really never had a preference, but there are recommendations to start with ARBs for that reason.
We do have another question in the chat. What's your preferred simplest way to evaluate for hyperaldosteronism?
To evaluate for hyperaldosteronism. Well, you can measure aldosterone and renin levels. That's really the way to measure the way to diagnose it. Another strategy is to just prescribe. If you have a patient whose blood pressure is not controlled, just prescribe the spironolactone and see what happens. It's much simpler and cheaper to do it that way. The two things you need to be aware of are the fact that spironolactone on top of an ACE or an ARB may result in deterioration of renal function and or hyperkalemia. So you want to monitor for that. But it often does not happen, so people tolerate it pretty well. But that's what I would do.
Yeah, we can give it another minute or so. I don't see any other questions right now. I did put a couple reminders in the chat, especially about the CME survey. It'll appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. And then I did put a little reminder about today's session if you ever wanted to anchor your own session and how you can go about doing that.